Hi everyone, welcome to my talk entitled Mindfulness-based real-time fMRI neurofeedback targeting the default network in schizophrenia and depression. I have no disclosures. In 2020, mental health care spending reached $280 billion in the US alone, with incalculable costs in productivity, disability, and loss of life. The COVID pandemic, as you can imagine, exacerbated the mental health crisis even more. And unfortunately, gold standard treatments are not effective for all. We identified one mechanism for action, which is the default network, where in schizophrenia and depression, hyperconnectivity within the default network is associated with symptom severity. Highlighted here are two keynotes of the medial prefrontal cortex and the posterior cingulate cortex of the default network. Additionally, default network has hyperconnectivity with disorder-specific regions as well. For example, in schizophrenia, it has been suggested that auditory hallucinations may be due to hyperconnectivity between the medial prefrontal cortex and auditory regions. And in depression, hyperconnectivity between the default network and the subgenual anterior cingulate cortex has been observed and is associated with symptom severity as well. We developed a personalized circuit-based intervention targeting the default network called mindfulness-based real-time neurofeedback, or mbNF. Mindfulness trains one to focus their attention to the present to reduce rumination and has been shown to reduce default network connectivity. In this setup, participants lie in the scanner and practice mindfulness. In real time, we send the brain data to a computer for analysis, which then we can display back to the participants so that they understand whether they're able to up or down regulate the activations within their brain networks of interest. This method has the advantages of being able to send feedback in real time, and we're able to personalize brain networks, and we're able to use circuit-based information instead of individual brain regions. In this talk, I will show data from two studies. Participants in both studies were trained on a mindfulness technique and underwent resting state scans before and after mbNF. The schizophrenia study consisted of 25 schizophrenia patients with auditory hallucinations, and participants were instructed to use mindfulness to upregulate brain activity while listening to pre-recorded sentences in their own voice and downregulate brain activity while listening to sentences in a gender-matched other's voice. 12 subjects were randomly assigned to receive real feedback from the superior temporal gyrus region that preferentially responds to self-voice relative to other voice. And 13 subjects were randomly assigned to receive sham feedback from their somatomotor network, identified using an independent component analysis of a localizer resting state scan. The depression study consisted of 9 participants with current or lifetime history of depression and/or anxiety disorders, and all participants received real feedback based on default network activation relative to central executive network activation, and were instructed to use mindfulness to downregulate the default network and/or upregulate central executive network. For both samples, we ran C-based functional connectivity analysis using an a priori seed and tested for functional connectivity change and baseline prediction of outcome post-mbNF. As you can see in both studies, mbNF reduced connectivity between the MPFC seed and the posterior cingulate cortex. Importantly, in the schizophrenia study, participants who received real neurofeedback showed more reduction in within default connectivity than sham subjects, and all the participants in the depression study showed a reduction. We also observed reduced connectivity between DMN and disorder-specific regions as hypothesized. In the schizophrenia study, MPFC STG connectivity showed more reduction in subjects receiving real versus sham neurofeedback. And in the depression study, subjects showed reduction in MPFC sgACC connectivity. And in both studies, all individuals receiving real feedback showed reduction at the subject level. Lastly, we have previously observed an association between reduced MPFC STG connectivity with improved auditory hallucination symptoms, although it did not replicate in the current study. However, in the depression study, reduced MPFC sgACC connectivity was associated with increased state mindfulness. Across two samples differing in diagnosis and age, we showed that one session of mbNF led to reduced functional connectivity both within the default network and between the default network and disorder-specific regions. Future directions include studying the longitudinal impact of mbNF, fine-tuning and personalizing mbNF parameters, as well as testing the benefit of mbNF in at-risk populations. We also hope to combine mbNF with experience sampling to identify vulnerable periods where mbNF should be triggered. I'd like to acknowledge my advisor, Dr. Susan Whitfield-Gabrieli, as well as acknowledge my collaborators at Northeastern University, Columbia University, VA Boston, Massachusetts General Hospital, as well as McLean Hospital. I hope you enjoy a wonderful OHBM 2023. Thank you.